next inviting Dr. S.K. Ajayakumar. This topic is exploring the advances in diabetic food management.
Dr.
Please.
Ajayakumar, Director and Chief Consultant, Saraswati Institute for Minimal Access Surgery, Thiruvananthapuram. Over to you, sir.
Respected chairpersons, senior teachers, my dear friends and younger colleagues. In the coming 12 minutes, I'll be presenting some recent advances by picked and choose method. I bring greetings from Government Medical College Trivandrum, which is my alma mater, and Saraswati Hospital Parasala, which is a diabetic food care and bariatric center. So as you know, offloading has got golden standards like total contact insole, different orthosis, and now we have very good sensor shoes, offloading shoes with sensors attached in the insole, which will automatically offload the areas of pressure where, for example, if the pressure is more than 600 kilopascals, automatically offloading happens. Just like your insulin pump assessing, sensing the blood sugar and giving enough insulin. So, and this intelligent plantar pressure offloading will have a big role in future and probably may replace all the complicated footwears. And this classical surgical debridement is there, and this is a small point for the juniors, the presence of biofilm. Many of us surgeons miss this, and this is a medically important complex structure. It is made by the microbial associated cells, its debris. What happens is all the bacteria live inside this biofilm. So whatever you do, systemic antibiotic, local antibiotic, it will not kill the bacteria. So the wound will never heal. So my younger colleagues should keep this in mind, and there are a lot of measures to remove biofilm surgically, enzymatically, chemically and all. And a lot of non-surgical debridement methods are there. Jet force, it's a water jet. You can see the high jet of water will remove all the dead tissue, and the live tissue will be there, and you are actually in addition to cleaning, you are converting a chronic ulcer into an acute ulcer, which hastens healing. Then lasers are coming in a big way. Erbium YAG laser with Recosmo technology. Then ultrasound wound debridement, which is very effective. In my personal experience also, it reduces the healing time very much. So this cleans all the dead tissues and the live tissue is spared. So there is no blood loss also. And we have the same CUSA knife machine. Sawing is used by surgeons very widely. This prop, you just keep on doing like this unless you can visually see how these are removed. And only thing is you have to keep a face shield or something, because it produces a lot of droplets. If it is infected, that will affect the surgeon. And this is the result, and it is very useful, and it's high time that we should all start using in our hospitals. Then topical oxygen therapy. Initially we all thought there was no effect on topical, only hyperbaric was effective. Now literature is coming, and you can use topical oxygen therapy. And hyperbaric oxygen, you know, I need not explain more. You have monoplace chambers, multiplace chambers. It increases the plasma level of oxygen by in more pressure in the inspired air. And VAC has come in a big way. No need to emphasize. Almost all centers use VAC. There is almost no contraindication except a severe wound ischemia. Then erbium YAG laser. These are some of the results. Then carbon dioxide laser can be used for debridement. You can see the laser beam removes the scab, necrotic tissue. Then there is another VersaJet hydrosurgery, that is also a form of water jet. Then local antibiotic delivery is a very important obstacle in case of ischemic wounds, renal dysfunctions and all. So there comes the role of antibiotic beads, stimulant. You all know about it, I need not explain. Only thing is the dose should not be very high. The common mistake surgeons do it, they put a lot of beads and the concentration is very high. If you have to make a judgment, the wound need not be filled with beads. That means you are putting a very, very high concentration in the local area. That is the only point you have to keep in mind. And this is widely used in orthopedics also, in deep-seated wounds with osteomyelitis and all. Then a lot of, I have not touched the dressing materials, a vast subject. I have not included in my talk. Still, tissue engineered skin substitutes, dermal scaffolds have come in a big way in granulating wounds. You can place it and you get very good wound bed. Even if you do a skin grafting, the result will be better, and some may not need skin grafting. Then regarding revascularization, as you all know, we have angioplasty and bypasses, and there is a role for stem cell therapy. As mentioned in the last talk, if the reconstruction is not at all possible and there is chronic limb-threatening ischemia, the role of stem cell therapy is there. It's adult human bone marrow derived cultured pooled mesenchymal strong cells. These stromal cells come in a temperature of minus 250 degree in liquid nitrogen, that is reconstituted. 15 ml is reconstituted with 35 ml of solution. That 50 ml is injected. The 40-45 ml in the same calf muscle as like this, and around 5 ml around the ulcer. We have a good series of patients and the results are fantastic. Initially we all thought, how does this work? It will take more than 3 months and all, but the results are very encouraging. Dear friends, the role of angiosomes are very important in distal revascularization, as you all agree. The interconnections between the two territories plays a crucial role in the outcome. And this you can see when it comes distally, there is complete absence around the ankle. You can see that. So such wounds, if now the posterior tibial artery is patent after revascularization. So even very distal revascularizations are possible, unlike the popular belief. The infrapopliteal lesions are generally not giving good results. The reality is not the same. And it is high time that we surgeons take up preventive podiatric surgeries, because surgical offloading is the one which we never do so far. And starting from callus cutting, you have a lot of surgeries available to generate interest in the younger colleagues. I'll show some. This is a very simple procedure where the ulcer, the tip ulcer, toe tip ulcer due to clove toe is prevented by just severing the flexor tendon using a needle, blood set needle. So needle tenotomy is an office procedure. Patient can go home immediately after the surgery. Then the one which often we miss is the tendo Achilles shortening and functional equinus leading to recurrent forefoot ulceration. The classical open tendo Achilles lengthening by Z-plasty or closed TA lengthening by multiple partial cuts followed by forceful extension of the ankle joint. So that is a solution for the then gastrocnemius soleus recession. That is another one which is more long lasting than the tendo Achilles, and there is less chance of heel ulceration. In the zone 2, that is the aponeurosis portion as well as fleshy portion of the calf muscle is there. You make an incision and cut the aponeurosis completely till you see the muscle fibers and start exercising and keep the muscle stretched, and it gives a very good result, and the chance of overdoing and heel ulceration is less. Keller's arthroplasty is the case actually presented in the quiz. You may remember there was a large ulcer in the plantar side. That should be treated with the Keller's arthroplasty along with revascularization. So removing the proximal portion of the proximal phalanx makes the big toe flail, and the pressure effect, the constant pressure on the side is removed. So a lot of measures are there. I am leaving, and preventive podiatric surgery should be there as part of our treatment protocol, because surgical offloading can do wonders. So thank you very much. I am inviting you for next weekend a hernia workshop in Trivandrum. If possible, please attend. And in September, Diabetic Foot Society of India National Conference is happening in Mumbai. So I invite all of you. I am very happy that diabetic foot is gaining momentum in ASI. Thank you very much for the patient hearing.
Thank you, Professor Ajayakumar, for the excellent presentation topic. He has doing wonderful work. When you look at it, we are becoming jealousy actually. So this wonderful work. The main problem we find is that the revascularization, even though study revascularization, where can we get such a revascularization procedures, where we can do it or not?
Yeah, there are two sets of physicians doing revascularization. One is a cardiologist, intervention cardiologist, interested in peripheral revascularization. That is a small group. The other one is an interventional radiologist. Both of them can help you. And in your team, it's a multimodality treatment, you know. The interventional radiologist or a cardiologist interested in revascularization should be there. Second is the cardiovascular surgeon.
Yes.
First of all, Ajay, congratulations. It's a brilliant talk as usual, and thanks for your initiative on the diabetic foot grounds. I just have one more question to add on to you, because it has been discussed that the human growth factor, local infiltration, has got some advantage over for healing purpose, especially in vaginas 1, 2, 3. This has been practiced in centers, especially in Cuba, and where it's very well advanced diabetic foot care society work going on. I happen to interact with them because for the government of Kerala with regards to this. And I just want your opinion regarding and your views because you have been
Regarding I didn't
human growth factors. Human growth, they
Yeah.
have a product called as Hebaport P, and it is used as an intralesional injection around 3 times a week, for especially for vaginals 2 and 3.
Yeah.
And they found that the reduction of the amputations have come down from 40% to around 17% at this point of time. And they recommend it. But since they are not allowed to be marketed outside Cuba, that is a problem because of embargo. But I just wanted, because you are going in
Yeah,
this forum for a long time, please.
I have no personal experience or knowledge about this one, but growth factors have an important role generally. Platelet-derived growth factors, GCSF, and epithelial growth factors. We all use topically. And the main problem, there is reduction of growth factor and overaction of MMP. That is a molecular level problem in wound healing in diabetes. Either you supplement growth factor and you surgically remove the hypertrophic scars. So, platelet-derived growth factor in correctly chosen wound can hasten wound healing, and for skin growth, epithelial growth factor is very effective. Regen D is the brand name. About this, I have no experience.
Exactly, because I also not heard about it. But when we had a discussion with the key group from Cuba on diabetic foot, and they have got a diabetic foot consortium there, it's found to be quite attractive. They have treated around 11,000 patients on it, and it's all true data also. And so they were asking whether we can be part of it.
Yeah,
but
we are only happy to
but
associate.
there are a lot of embargo to get over.
Yeah,
it.
I know. But in the international arena, this
Seems
has
to
not
be
come.
very interesting. If the cost-wise, if it is viable, I think there's one more option we can think about in this. Thank you so much.
Sir, any role for PRP installation?
Yes, definitely. I personally use also. We can make PRP or you can make PRF. You can allow the blood to clot and platelet-rich fibrin, and gel-like it will be placed there with a collagen membrane or something to hold it, and we are using it.
Last comment, sir, please. Thank you.
Thank you, sir. There is another group of people who do revasculars, vascular surgeons. And we being surgeons, we should be more friendly, and we should not be friendly to cardiologists and radiologists. And there are studies to prove that the intervention done by vascular surgeons are much better than radiologists and cardiologists.
Correct. 100% agree. Thank you.
Okay. Thank you, Ajayakumar.
May I